So thank you. As you've all heard, my name's Peter Haggert, CLL Canada, and I have Deborah Henderson with me.
Who is also not Pierre Aumont.
And also not poor Pierre, who can't join us today, unfortunately, but Deborah has courageously stepped in at the last minute. So for the last 48 hours, we've been rehearsing this nonstop. But actually, it's a very special section. I'm very glad. CLL diagnosis, active monitoring, and associated dilemmas. Now, throughout Nick's presentation, Nick often spoke about Anna this, and Anna that, and Anna this. It's because Professor Anna Schuh is one of the preeminent names in the CLL community, and we're very privileged to have her today to open this session. And I spoke with Professor Schuh earlier, and she sent me just a very short bio material here. That's not her. I don't know who that is. Don't you just love this? It's changed our world. Professor Molecular Diagnostics, Department of Oncology, University of Oxford. Consultant hematologist with an interest in MBL, CLL, and EBV-positive Burkitt's lymphoma, senior facility, Unimbili University of Health and Allied Sciences, Dar es Salaam, Tanzania. Tanzania. I'm sorry. I've done that since I collected stamps as a youngster. Principal investigator of over 50 early late phase clinical trials in CLL. Board member of the IWCLL, chairs Global Partnership Subcommittee, leads research into precision diagnostics in hemato-oncology, including whole genome sequencing and liquid biopsies in the UK and East Africa. Directs the Oxford Online Master Program in Precision Cancer Medicine, co-founder of Serenox, I apologize if I butchered that, as a social enterprise to improve access to diagnostics and precision medicine in Africa. Please, a warm round of applause for Professor Anna Schuh.
Sorry for that. Yeah, thank you very much for, can you hear me okay? Sounds very loud in my ears. Thank you very much for Clantor giving me the opportunity to talk to you today. So they've given me quite a difficult task, and it started off with chronic lymphocytic leukemia from the beginning. And I will go a bit more into, these are my honorarias. Don't have to go through them. So basically what the committee said is I should talk through the entire CLL diagnostic process, what is important to the clinicians and what is important to the patient. I should talk specifically about active monitoring and the whole watch and worry problem. I should then focus on approaches to more personalized management, and individualized patient care, and then at the very end I should also talk about some research. So and all of this in 25 minutes. So I'm not going to be able to do that. So what I was going to do is just focus on a few important aspects. So before I start, though, and I'm sorry to bore you with this, but it's kind of quite important because as clinicians, this is what we are basing all our decision-making on. It's something called Kaplan-Meier curves. And it's basically the main output that comes from clinical trials when we are comparing one treatment against another treatment. Very often we're doing this in an approach where we ask the computer to randomize patients, so to put half of the patients into one arm and the other half of the patient into another arm of treatment, and one arm gets the standard of care and the other arm gets the new treatment, and then we're comparing. And at the end of it, we're plotting essentially the time it takes on the x-axis and then on this horizontal axis, and then the time it takes for patients to relapse or die is on the other axis, on the vertical axis. So as you hope this is working, yeah. So as you see. This is basically when you see these tics, it means that the patient has lost a follow-up. When you see a step, it means that the patient discontinued the drug for any reason. It might be because the disease came back, or it might be because the patient died, or it might be because the patient stopped treatment for side effects. Then the other important measurement is this thing called median survival. So at the 50%, this is the mark where 50% of the patients have either died or they have progressed from treatment, depending on what type of curve it is. And then the 1 year survival is basically here. You see these are this is the 1 year point. So you know that at 1 year in this particular Kaplan-Meier curve, only 20% of the patients are still on the drug, and they're still either they have survived or they have not relapsed, depending on what we're looking at. So these curves are really important, and I will show you quite a few of them just to highlight why I'm coming up with the conclusions that I'm coming up with when it comes to treatment decisions. So before I start though, is that when patients are first diagnosed, and I'm talking now from the perspective of a clinician, it's really complicated because we obviously know that patients are having to deal with the C word, and in many parts of the world, the C word is still a word that is almost synonymous to I'm going to die in the next 6 months. And so as clinicians, we really have to be very mindful of that and how we're dealing with this issue, in particular for patients with CLL, where this is absolutely not true. Right, so in CLL, the outcomes have improved very dramatically, but there is still a lot of worrying going on, and some of that worrying is because, unlike many other cancers, we are not saying to patients, "Oh, you've got cancer when you need treatment," but we're actually saying to most of the patients, "You've got cancer, but you don't need treatment." So very often patients interpret this as because nothing can be done. The doctor isn't honest, he doesn't want to tell me, I'm doomed. So they go away, they sell their house, they go on a world trip, they divorce, they do all sorts of things that quite often we as clinicians don't even know, but they're very devastated. A survey a long time ago on CLL patients, over 1,000 patients, I can't remember who did the survey, but it was all about emotional well-being. And what came out of this survey was that patients actually with CLL had a lower emotional well-being compared to patients newly diagnosed with breast cancer. This is 15 years ago, when breast cancer was actually still associated with very bad prognosis for many patients. But because patients felt like they're being taken care of, somebody's giving them chemotherapy, they have a nurse, they go every week to their medical appointments, they actually felt quite reasonably comfortable. Whereas patients with CLL, in the UK, for example, very often they're still being told you go away, you've been followed up by your GP, who's not a specialist, who doesn't know, because they only have 0.5 CLL patients in their entire professional life that they see. So these are the issues really we're dealing with. So watch and worry is still very much an important problem. Importantly, though, there is support available, and there should be support available. There's family, friends, of course, increasingly clinical nurse specialists in jurisdictions like the UK, where clinicians are very busy and too expensive. So clinical nurse specialists play an increasing role in being the first contact for people and for patients. And then, of course, as we all know, the patient support groups, they're really, really important. And it's important to remember that you've got rights. And I put here down the NHS Constitution, but I would argue that these rights apply to any patient in any healthcare system. And it's important that as doctors we are reminding patients of their rights. And in particular, for example, in private healthcare systems or in very disjoint healthcare systems, it is very important that patients have got their records with them all the time. So they get copies of their blood results, they have copies of their scans, they have copies of letters that summarize, the state of where they are. These are things that as patients, you are very allowed to ask for, and nobody can refuse you, because that data is your data, and you should keep hold of it and you should treasure it, so that when you go to a different doctor or you're being admitted in an emergency situation or whatever, you have got all this information with you. And of course, you can always complain when you're not happy with your care, or you can choose a different doctor. I think these are very important points. So the good news is actually that when you're looking, at least in high-income countries, or in registries of high-income countries, including that of the UK, when you look at the registry data, it shows that that the death, the causes of death and mortality due to CLL is very much decreasing quite rapidly since we started giving targeted therapies. And that started around 2010, when we started giving rituximab and added that to chemotherapy. And it's since then continued with introducing ibrutinib and then introducing venetoclax and so forth and so forth. So that you can see in the most recent data that was published end of last year from Italian and US groups, you can see in the dotted line is basically the normal life expectancy and survival probability of age and gender matched normal people without CLL, and the normal other potential diseases that they might have. And when you're looking at the curves for patients who are treated with either ibrutinib or similar drugs, or venetoclax or similar drugs, in green and in the greenish colors and in the bluish color, you see that there's almost approaching normal life expectancy. So what I'm saying to patients, in 2024, when they're asking me, because they all ask, of course, what is my life expectancy if they're being newly diagnosed, I tell them I will make sure, or my endeavor is to get you to your normal life expectancy, which in the UK for a male is about 80 years or 79 years these days. For a woman is 82 years. But obviously when I'm in Tanzania, that might only be 62. So I'm trying to say, you're not going to die of CLL, you're going to die with CLL. Eventually, you're going to die of something else. And I think that's basically where, in the high-income setting, thanks to the new therapies that we have available, we are already there. When you're looking at the chemotherapy curve, which is basically the treatment that most people get in the world with CLL, in red here, you see that clearly that curve is separating out, and it's less than the normal life expectancy. And that's really, for me, the most powerful evidence over the last 10, 15 years now, the most powerful evidence that all the advances that we've experienced in CLL treatment have actually had very much a positive impact. So, this is a bit not really sharp, I don't know why, but essentially this is my slide on how to diagnose CLL. So when one of the issues we have around the world, I will briefly mention this, is that in lots of parts of the world, in particular where people live, so in remote areas, full blood count machines are still not available. That's the reason why chronic myeloid leukemia is diagnosed late, and does not actually respond that well to treatment once patients are started on it, and why CLL is diagnosed really late, usually with stage C disease, benign stage C disease in those settings. So for me, the really important part, if ministers of health are asking, around the world, what do I have to invest into? It's a full blood count machine. In most jurisdictions, the machine only measures the hemoglobin. So when a hematologist says, oh, you're anemic, they might say, oh, you're iron deficient, you're vitamin B12 deficient, you've got sickle cell disease, you've got something wrong, in your red cell production. They don't see that the white cells are high, which is the diagnosis of CLL or CML or even an acute leukemia. And as populations are transitioning into Western lifestyle and they're getting older and life expectancy is improving, then the probability of having a leukemia is much higher. And so that's why we need proper full blood count machines. And in addition to that, we need the blood film that goes with the full blood count. And so here you see like the CLL cells in the blue dots, and then you see the pinkish sort of smudgy things. Those are smear cells, we call them smear cells. And they are CLL cells that burst in the process of preparing the smear of the blood film. And that's really how, looking down the microscope, most clinicians in the world still make the diagnosis of CLL. The problem with that is that sometimes this is not a typical picture like this one here, but it might be atypical, and then you need flow cytometry to confirm the diagnosis. And in high-income setting, we'll routinely use flow cytometry, and then we use markers against specific proteins that are expressed on the CLL cells to confirm that this is really CLL and not another type of lymphoma. There was a question early on in the audience about lymphoma. There are 200 different types of lymphomas, and there's many different types of leukemias. And so it's very important that you're dealing with the right disease, because they are all treated in a different way. And then in many settings, we would then do the immunoglobulin mutation analysis and the TP53 testing. Now, those are basically TP53 mutations are a prognostic marker. So whenever patients have the mutations or deletion in TP53, then that's still associated with a slightly worse prognosis. The same for immunoglobulin status analysis, and we'll talk about this in a bit more when clinicians are telling you about this. There are two completely different types of CLL, the ones that have hypermutated and the ones that are unmutated. When you're unmutated, you might need treatment within a few years. When you're hypermutated, very often patients can go for many, many years without needing treatment. So, and I won't go too much into the details of this, but this is all being written down in a WHO Blue Book. We have got, the WHO is issuing books for cancer diagnostics for lots and lots of different cancers, including the hematological cancers, so the blood cancers, including the lymphomas and the leukemias. And so there are two big books. They were recently newly edited, and I was very honored to be part of the editorial board. And a lot of work has gone into this, into making this diagnosis accessible to all parts of the world. So for the first time, we have basically divided up the diagnostic criteria into essential criteria and into desirable criteria. And the essential criteria are there to ensure that health systems around the world are pushed into providing these very essential tests to patients with CLL, whereas the desirable criteria are basically there to, to further research projects, clinical trials to help with more advanced diagnostics that is not really necessary to provide routine clinical care. And I think that's a very important message, because this is the WHO. This is not CLAN. It's not like any kind of committee of clinicians, who sit down on a Sunday afternoon. This is the WHO. If the WHO says in a blue book that this needs to happen, it has to happen. So we need to go, to our ministries, and I know this is very difficult, but we need to tell them when people are saying, well, we don't have a flow cytometer. Well, for this test, for this essential test here, you need a flow cytometer. For this essential test here, you need sequencing or FISH or whatever other technology the laboratory needs. And then, if the government was listening, which of course they don't do, but if they were listening, then they would have to comply with this. It's a bit like the WHO list of essential medicines. And increasingly governments are complying with that list. They should comply also with the diagnostic book. So coming back to these Kaplan-Meier curves. So the reason why TP53 mutations, deletions, why this is an important test is basically in the era of chemoimmunotherapy. And as I said, many patients are still treated with chemoimmunotherapy. If patients have a TP53 abnormality, either deletion or a mutation, they do much, much worse on immunotherapy. And this is the patients in the blue curves. So you can see that in the era of chemoimmunotherapy, the progression-free survival, so the time it takes for patients to relapse, over half of the patients will relapse within the first 2 years. So because FCR treatment is quite an aggressive treatment, over 25% of people have to go into hospital when they receive FCR with infections and so on. That is not good management because half the time they'll be in hospital, they have 6 months of treatment, and then a year later the CLL is back. So this is not good treatment. So everybody who needs treatment needs to be tested for TP53, in particular in jurisdictions where chemoimmunotherapy or chemotherapy is the only treatment that is available. But even in the era of targeted therapies, especially with a fixed duration therapy, you will see that the curve of the patients with TP53 mutations, which is the blue curve here, it separates out from the patients who are wild type, who don't have the TP53 mutations. So again, this is why we are saying, in the medical world, when you give venetoclax obinutuzumab combination, or you give venetoclax ibrutinib combinations, anything that is fixed duration over a year, we believe that if patients have got the TP53 abnormality, then that will lead to a quicker relapse. Whereas if you go on to continuous therapy with a BTK inhibitor, like ibrutinib or acalabrutinib, you see in red the curves here. It's actually there's no difference in treatment outcomes. Patients do very well. In blue, it's the curve with the chemotherapy treated patients, and you see how big the difference is between chemotherapy in blue and the TP53 wild type or mutated patients when they're treated with acalabrutinib. So that's really sort of some of the evidence and some of the reasons why this test is a really important test. And we have to repeat this test every time patients start new treatment, because these mutations, they can occur at any time point in the course of the life of the patient. So when we're talking about the immunoglobulin status, as I said, there's 2 different types of CLL. There's the unmutated ones and the mutated ones. This is very much historical data. It's over almost 25 years old now, from Southampton, and it was the first time this was described, and it showed what I've already said, is that patients who are hypermutated have a longer time to first treatment, and they also survive longer than patients who are unmutated in the immunoglobulin status. So this is, rather than being like a test for response to treatment, is more of a test for how the biology of the disease is. So why watch and wait? Why, once we've done all these diagnostic tests, why are we not, as clinicians, going in and starting treatment straight away? Because basically a long time ago, many studies with using many different types of chemotherapy actually have shown that it does not alter the disease. It doesn't alter the natural history of the disease. There's no difference in overall survival if you start early or if you start late, at the time when the patient is becoming symptomatic. And that applies for just giving chlorambucil, this is a study from back in the late 90s, to fludarabine, single agent, again, where there was no difference. This was a study where people were divided into high risk and low risk. So the low risk are usually the hypermutated CLL patients, the ones that are doing well anyway, and then the high risk patients were given either treatment or they were giving no treatment and had watch and wait. And you can see there's absolutely no difference between the green curve and the blue curve. So early treatment doesn't make a difference. And even with the ibrutinib, this is a recent study from the German CLL study group, they did the same again. They divided patients into high risk and low risk, and then they looked at watch and wait in the high risk and watch and wait in treatment in the high-risk patients. And again, there was absolutely no difference in overall survival between the groups. And that's really why today in 2024, we are still waiting until patients have actual symptoms, or they progress to stage C disease and they need transfusions or other support. Importantly, also with ibrutinib, actually, when you give it early in the study, there were a few patients, not many, but a few patients who got side effects, because we know ibrutinib, you can get side effects. You can get bleeding complications. You can get cardiac arrest. The heart can stop beating. It's very rare, but it can happen. And in fact, it had happened in some of those patients on the study. So this is not good, and this is really the reason why even in this era of targeted therapies, we are not treating patients early. We are only treating patients if they really need the treatment from a symptom perspective. So when is that moment? Has that moment come? And you heard, some of you heard this morning about the staging systems already. I'm more familiar with the Bini stage system because that's what I'm using. So basically, stage A disease is just a few, it's a lymphocytosis in the blood usually, and very few enlarged lymph nodes. No bone marrow failure, so no low platelets, no low hemoglobin. It never needs treatment. So, and most of the patients who present in a high-income setting will have stage A disease these days because they're diagnosed on an incidental blood test. Stage B disease, it's a very gray area, and it's very much a decision between the patient, the family, the doctor. Does it need treatment? Doesn't it need treatment? Because it depends on the symptoms. If patients have lymph nodes, some people have quite large lymph nodes, but they're otherwise fine and they're getting on with their life, they don't need treatment. If they get drenching night sweats, or they have a spleen, a large spleen, and it's pressing on their stomach and they can't eat because they're feeling full all the time, of course that's different, then they need treatment. The stage C disease patients always need treatment because they have an anemia that is usually symptomatic, they have low platelets, so they have signs of bone marrow failure. The very important message to the clinicians in the room is that the Bini staging, even in 2024, does not need CT scans. So many times, and this is one of the common mistakes I see in many parts of the world, is that patients with CLL are treated like lymphoma patients. They're treated by lymphoma doctors, and they end up having lots and lots of CT scans. This staging system does not work when you're looking at the CT scan because everybody will have lymph nodes and everybody will be stage B disease. So it's only clinical examination, and no CT scans are needed outside of clinical trials. What else should your doctor do when you're under active surveillance? Apart from reassuring you and saying, there's no evidence that early treatment is a good thing, don't smoke, use sun cream, prevent infections, and get vaccinated. Those are the really important messages. You all know about the vaccine situation and COVID. The really important ones are pneumonia vaccines. And there's a special regimen that we use in the UK, and that's simply because it's, number one, those are the vaccines that are available, but number two, it's also because the sequence of the different vaccines is very effective. Never have an active vaccine. So in GSK, high-income countries, you might get access to a shingle vaccine that is inactive, that is sold by GSK, so that's a good thing. But don't have the active form, which is the one that usually is available around the world. Don't have yellow fever vaccination, because that's an active vaccine for those who live in tropical areas. So there's certain things that you have to keep in mind. And despite the fact that we are really struggling with antimicrobial resistance and antibiotic resistance, CLL patients or hematology patients are the exception from the rule. So if your GP, your health practitioner says, oh, just fight it out, it's just viral, don't listen to that. You are a CLL patient, you have immune suppression, you have the right to have 2 weeks of antibiotics. And that is another thing that people very often clinicians very often don't integrate that when you have CLL, there's a high chance or risk that you have got secondary immune deficiency, that you develop changes in your lungs that make you more prone to getting certain types of bacterial infections when you have a viral infection, and that warrants treating with antibiotics. And some patients even get prophylactic antibiotics, or they get immunoglobulins to prevent those infections from recurring all the time. I actually think this supportive care is very much also underestimated in busy hematology clinics when hematologists are now just trying to save life and give CAR T cells. They don't focus so much on the supportive care. So when to consider treatment, these are the alert symptoms that you have to look out for. I've already mentioned them, new lumps, drenching night sweats, etc. So then in my last few slides, I will talk about some future approaches, and I can't talk about everything, so I thought about talking about something that is appropriate to this session of early intervention and watch and wait. It was actually thanks to input from Nick and his colleagues that a few years ago in the UK we started thinking about how we can address this whole issue of watch and worry and watch and wait and watch and worry. And so I had a little think about what kind of studies we could run, and I went into the literature, and so there is an international prognostic score that was developed by various groups on the basis of some retrospectively collected data called the IPSC. So this is the international prognostic score for early CLL. And essentially, this is a very clinical score. It uses three informations, whether the patient is unmutated or hypermutated, whether the lymphocyte count is over 15 or less than 15, and whether there's nodal involvement or not. And according to those three things, you're then classified into low risk, intermediate risk, and high risk. And you can see, that when you're high risk, it's quite a good predictor. If you're high risk, then really that the time to treatment will be median time to treatment will be in the order of 2 to 3 years, really. And when it's low risk, it's also kind of good prognostic factor, because you can see about 80% or so will not need treatment even after 28 years. So that's quite good. But the people in the middle, which are the intermediate risk, is the vast majority of the patients. And so they are not really being classified in a good way. And so we were asking the question, can we improve this somehow? And so we started a study where we recruited, almost 500 people with early CLL or MBL, so monoclonal B-cell lymphocytosis. The study was also open for patients with early multiple myeloma. I won't talk about this. And then we did a lot of kind of tests. We took samples from them. We see them every year. We ask them questions, how they feel, have they had infections, did they have COVID? Did they get their vaccines? So there's a lot of clinical data that we collect, but then also a lot of sampling that we do. And we basically had 16 centers across the United Kingdom, and we used very much media, online media, but then also the NHS networks and of course the patient networks for the patient recruitment. This was during the pandemic, so it was very, very challenging, and it wasn't completely straightforward. But the study is now closed for recruitment, and we are busy going through the analysis of all the samples. We do whole genome sequencing. We're looking at the immune system of those patients, doing T-cell studies. And we have, hopefully, by next year, we'll hopefully have some quite interesting data. The idea being basically that we will be able to tell people, actually, it's not just 80% certain that you will never need treatment. It's now 90% certain you'll never need treatment. And equally, for the high-risk patient or the intermediate-risk patients, we'll be able to say, oh, actually, for you guys, you are now falling into the high-risk group, or you're now falling into the low-risk group, and we can give a much clearer clinical advice on how to proceed. And the other idea behind this is that for the very few people who will need intervention or might benefit from intervention, that we would be able to offer this intervention. If they're very high-risk people, we wouldn't give them ibrutinib because that was shown to have very bad side effects in a few patients. But what we are currently doing is developing a vaccine. So with the Oxford Vaccine Group that developed the COVID vaccine, the COVID AstraZeneca vaccine, we're using a very similar approach, but this time we're using proteins that are expressed on the CLL cells in the hope that the vaccine would help raise an immune response against those early CLL cells. The idea being that if we vaccinate early, then maybe we can cure those patients rather than just controlling the disease as you would do at the moment when you need treatment. Because we know it's not, CLL on the whole is not curable. We can control it with treatment. But maybe if we are treating very early on and they are high-risk patients and we can reactivate the patient's immune system through vaccination, we might be able to cure some of those patients. So that's really kind of the hypothesis and the rationale behind this. But we need to have those markers of whether patients are high risk or not, because we can't vaccinate everybody. You saw like 80% of patients with the lower risk IPI, they don't need a vaccine. They will be fine anyway. So we need to do a very clever risk-adapted approach, personalization, that's his sort of personalization, and then giving only the people who really are at risk a vaccine. So that's kind of precision, what we're calling precision prevention, and this is a new concept, or relatively new concept, that sort of got a lot of momentum after the pandemic, because we identified ways of producing really very immunogenic vaccines, and that's why there's a lot of interest now, not just in CLL, but there's lung vaccines, there's a colorectal cancer vaccine study nationally in the United Kingdom using, again, very similar approaches, but RNA vaccines. The beauty of this one is that, of this ChAdOx2 approach, and then I finish talking, is that it's very cheaply to produce. The RNA vaccines are still very expensive. ChAdOx2 is cheap. It's also very easy to produce. So if you were thinking of regionalizing vaccine production, taking vaccine production to areas outside into Africa, into India, it would be very easy. And the licensing of this is so the politics behind, the economics and the commercialization and so on are also sorted because it was the COVID vaccine. So there won't be any problems with access, for example, like you would have with proper commercial products. So in conclusion, survival of patients with CLL treated with best available therapy has significantly improved and is almost the same as that of general age and gender-matched population. This, of course, only applies to people in high-income settings. Ensure that, and I should say in high-income settings and those who can access those drugs in high-income settings, because there are also many who can't. Ensure that you understand which type of CLL you have, whether it's unmutated or hypermutated, whether it's TP53 mutated or not. Keep a record of all your results. There's no role for early treatment outside of clinical trials, but maybe there will be a clinical trial of vaccination soon. Ensure that you are up to date with vaccinations and lead a healthy lifestyle. I think that is very important. And a lot of research is aiming to harnessing the immune system to fight CLL. CAR T-cell is one of the approaches. It's an extreme approach. Bispecific antibodies is another one. There are many different ways to do this. Therapeutic vaccination that I spoke about is also one of them that is sort of slowly emerging. Thank you.